Doc, start tayo in 1 minute. 4:05.
Bakit pang?
Okay, Doc, we can start na po. Doc Francis. Wala ba? Hello, Doc Francis. Nawala yata. Hello, Dr. Estrada. Ang nawala. Doc Jeff, okay na yung kay Dr. Velasco?
Sir, parang ako yung mauuna.
Ah,
Pinaligtad na lang yung yung sequence.
Okay po.
I can start
mukhang
if you want na.
Okay po. Sige, Doc. Stop share ko lang yung kay Doc.
And then we shy away na lang muna for the introduction. Siguro kahit later na yun. Is that okay?
Sige po.
Okay, para we can start. Can I share it na?
Wait po. Stop share. Na-try po, i-share na yung slides niya.
I cannot share kasi naka-share pa yung kay Dr. Estrada. So parang kailangan niya or someone from you from there.
Can you hear me na? Narinig ako?
Yes.
Ayan na yata si Doc.
Okay.
Doc, ready ka na? Okay na.
Yes. Ready.
Okay. Sige po.
Okay.
Start na po.
Okay. Good afternoon, everyone. I am Dr. Francis Gerard Estrada, your moderator for this afternoon's webinar. And I would like to welcome you to the third part of the webinar series, which is organized by the Philippine Thyroid Association and the Philippine Society of Newborn Medicine in celebration of the International Thyroid Awareness Week, with the theme Thyroid Issues, Mother and Baby. This afternoon's lectures will focus on the short and long-term effects of thyroid dysfunction in the newborn. Before we proceed, we would like to acknowledge Merck and the Telemedicine Network of the Philippines for their invaluable support and contribution in organizing this webinar. To start with, let me present to you the house rules. This webinar is being recorded, and to avoid any interruptions, all your microphones will be muted during the course of the lecture. If you have any questions and comments, you may type them in the chat box or the Q&A box. We will collate your questions and comments, then raise them to the speakers during the 20-minute open forum at the end of both lectures. We thank you for your cooperation. Let me now present to you the course objectives. Number 1, to discuss the short and long-term effects of hypothyroidism in the newborn. Number 2, to discuss the effects of hyperthyroidism in the newborn child. And number 3, to explain the management of hypothyroidism and hyperthyroidism in the newborn. Let me introduce to you our two speakers. Our first speaker is Dr. Belen Amparo E. Velasco. She is a diplomate and fellow of the Philippine Pediatric Society and Philippine Society of Newborn Medicine. She is a medical specialist and research officer at the Philippine Children's Medical Center. She is currently the president of the Philippine Society of Newborn Medicine and is currently affiliated with the Philippine Children's Medical Center. Our second speaker is Dr. Eric Mendoza. He is a diplomate and fellow of the Philippine College of Physicians and Philippine Society of Endocrinology, Diabetes, and Metabolism. He is also a member of the Department of Biochemistry, Molecular Biology, and Nutrition of the University of Santo Tomas, College of Medicine. He is the head of the Scientific Committee of the Philippine Thyroid Association and the Diabetes Weight Management and Clinical Nutrition Center of the Allied Care Experts Medical Center, Valenzuela. He is affiliated with several hospitals in Metro Manila, namely University of Santo Tomas Hospital, Hospital of Infant Jesus, St. Luke's Medical Center, Quezon City, and Allied Care Medical Specialist Center, Valenzuela.
I'll start na? Or
Yes.
si Doktora?
Okay, so we will now start with the lectures. To start with, may we welcome Dr. Eric Mendoza. Yes.
Good afternoon, everyone. Thank you to the Philippine Thyroid Association and the Philippine Society of Newborn Medicine. The first part of our collaboration will be the neonatal hyperthyroidism. So these are the objectives of this lecture: to discuss the pathogenesis, clinical effects, and diagnosis of neonatal hyperthyroidism, to explain the management of neonatal hyperthyroidism and its sequelae. In neonatal hyperthyroidism, almost always it is secondary to maternal Graves' disease. And when we deal with maternal Graves' disease, we want to evaluate the three factors involving maternal thyroid activity, TSH receptor antibody, and anti-thyroid drugs that is being used. There are other rare causes of hyperthyroidism, such as activating mutations of the TSH receptor, activating mutation of the alpha subunit of GS protein, giving rise to McCune-Albright syndrome. But these causes are rare, and I think you will not encounter this in your clinical practice. So I will focus on neonatal Graves' disease. There is a short-term effect of neonatal Graves' disease, and it is usually self-limiting, but sometimes it can be severe and it can be life-threatening. Also, there are a few studies showing long-term effect on neurodevelopmental impairment when the patient is exposed to high level of thyroid hormones in the presence of neonatal Graves' disease. So first and foremost, let us have a brief review of what is the pathology in Graves' disease. The normal agonist for thyroid hormone production is TSH from the pituitary, and it is regulated by the negative feedback. The pathology in Graves' disease is autoantibody production that stimulates unregulated thyroid hormone production. There are three types of TSH receptor antibody, namely your TSH receptor stimulating antibody, or let's just call it TSAB, TSH receptor blocking antibody, or TBAB, and the neutral TSH receptor antibody, or NTRAB. Most individuals has the stimulating antibody or subtype, or the TSAB. Hence, only less than 10% has the blocking antibody or TBAB, and this subset can actually manifest with hypothyroidism. And more rarely, it can manifest as a patient switching from hyper to hypothyroidism and vice versa. TSH receptor antibody is very specific. It is not found in the general healthy population, and it is present in more than 80 to 95% of those with Graves' disease. Perhaps those with undetectable TRAB has intrathyroidal antibody production, and it is not detected in the circulation. So in this table, to your top left, presents the maternal and fetal sources of TSH, thyroid hormone, and TRAB, or thyroid stimulating hormone receptor antibody. TSH cannot pass the placental barrier, so there will be no transfer because it's a glycoprotein hormone. Fetal TSH production begins at 16 weeks, but not mature enough to respond to negative feedback. Thyroid hormone is exclusively maternal from 12 to 20 weeks. There is considerable but inadequate fetal production thereafter. Your TRAB is an IgG, so it can pass the placental barrier, and it is exclusively maternal. After all, the autoimmunity is of the mothers and not of the fetus. In the table below, you can see the three deiodinases, D1, D2, and D3. So these deiodinases convert your T4. The placental tissue in early pregnancy has abundant D3 that protects the fetus from excess thyroid hormone by converting your T4 to your inactive reverse T3. As pregnancy progresses, there is an increase in your D1 because there's a need for more thyroid hormone. And you can see it in the graph on your right. The reverse T3 decreases while your T4 and T3 increases. We should be familiar with the two assays used in the determination of your thyroid receptor antibody, or TRAB. The first one is a competitive binding assay that measures the quantity of TRAB in the blood using the principle of ELISA and chemiluminescence. The second is the bioassay that differentiates whether TRAB is predominantly stimulatory or inhibitory. So in a way, it's a qualitative method. It is only for research purpose, and what is available locally in some centers will be your competitive binding assay type. Since most of the time TSAB is the predominant subtype, there is no need to use this cell bioassay. You don't need to qualify if it's a stimulating antibody or inhibitory antibody. So there are 4 clinical scenarios in which a pregnant woman can give birth to a neonate with Graves' disease. So the first one is a stable active disease, and then also relapse in pregnancy after antithyroid induced remission, or it can be a de novo or a new onset Graves' disease. And the last one, the patients who underwent surgery or radioiodine therapy in the past, and they have persistent thyroid antibodies or TSH receptor antibodies. So I'm giving emphasis on the last subset because this is often forgotten. So patients who had Graves' disease in the past, rendering the mother hypothyroid, for example, by RAI or thyroidectomy, she can still harbor antibodies that eventually may traverse the placenta and cause fetal Graves' disease. In a series, antibody persists after RAI as a function of time, and also for surgery, it's a function of time with additional risk factors such as smoking history and presence of your GO or Graves' ophthalmopathy. So the perinatal course of Graves' disease is variable. Pregnancy is usually associated with immunotolerance. However, the most important determinant of persistent TRAB is the initial level, and it's related to its activity. Mothers with TRAB more than 4 times the upper limit of normal are less likely to achieve completely normal TRAB at 3rd trimester, unlike mothers with TRAB of less than 2 times the upper limit of normal. The final outcome is based on the maternal thyroid function, the maternal antibody level passing to the fetus, and also the use of antithyroid drugs. Remember that these antithyroid drugs can reduce your TRAb, and it can also hypothetically switch the stimulating antibody to a blocking antibody subtype. So worldwide, the incidence of Graves' disease is 0.2%. It may be higher in our country, but we need local data. The incidence of your fetal neonatal Graves' disease is 0.2 to 5%, reflecting population heterogeneity. 1 out of 25,000 newborns can have neonatal Graves' disease. Higher maternal TRAb in the 3rd trimester predicts the development of your neonatal Graves' disease or manifestation of that. And the American Association of Pediatrics recommends a cutoff of more than 3 to 5 times the upper limit of normal. So it's important to recognize that there are 2 subsets of mothers in which thyroid status should be ascertained. So the first mother is the one that has active Graves' disease, in which she has no treatment or has treatment but still the level of the thyroid antibody is elevated. This can produce fetal hyperthyroidism. And also if she is taking too much antithyroid medication, or if she has the rare TBAB or blocking antibody, it can cause both fetal and maternal hypothyroidism. Another subset of patients will be mothers who underwent radioactive iodine therapy and surgery before, and they may be hypothyroid, or they are hypothyroid but taking levothyroxine, so they are considered euthyroid. However, the presence of antibody can still cause isolated fetal hyperthyroidism if it's high enough to pass the placental barrier. Also, if there's inadequate levothyroxine intake or there's blocking antibody, there can also be fetal hypothyroidism. So take, for example, this case of a 34-year-old female with recent history of radioiodine therapy for Graves' disease 6 months ago. Not only thyroid function test should be requested, you should also request for TRAb. For one, it's just a recent radioiodine therapy, so there's a big chance that she still harbors the antibody against the thyroid, or antibody that can stimulate the thyroid follicle of the fetus. And the indications for TRAb assay are as follows: current Graves' disease post-RAI or radioiodine therapy, and thyroidectomy, subtotal or total thyroidectomy. Also, previous neonate with Graves' disease and previously elevated TRAb for some indication that it was determined. So the latest guidelines was from the Endocrine Society and the American Thyroid Association. This patient warrants TRAb determination from week 22, and since she is already at week 24, we need to take that into consideration. And repeatedly if it is elevated. In the local setting, it's very impractical to request your TRAb too early, I mean first trimester, because it may still go up during the 2nd and 3rd trimester. And if you request it too late, for example, at 30th week of gestation, there's a big probability that the result will still not be available prior to delivery. So I think it's wise to request it around 22 to 28 weeks. So it's just like the 75-gram OGTT. So repeated testing is also costly. Some clues in the prenatal ultrasound are as follows. You can see enlarged fetal goiter or fetal thyroid gland with a P95 with hypervascularization, which is a telltale sign of Graves' disease. And then you can also appreciate increased fetal movement, advanced bone maturity. And most of the time, what was really noticeable is your fetal tachycardia, more than 160 beats per minute. And its characteristic reactive NST and good heart rate variability. So let's see the natural history of maternal and neonatal Graves' disease. After delivery, the natural course varies on whether the mother is taking antithyroid drug or not. Infants from mothers taking ATD manifest at birth, while infants born from mothers who are taking ATD may manifest late. Sorry, the mothers not taking ATD at birth, and then those who are taking ATD it can manifest as late as 7 to 10 days after delivery because of the half-life of methimazole or PTU. Most of the subclinical course peak at day 5, but there is normalization usually at day 14. It is worth noting that true neonatal Graves' disease resolves spontaneously because the antibody is from the mother's body and it is eventually cleared from the fetal circulation. So unlike maternal Graves' disease, she may or may have remission, but neonatal Graves' disease, they have spontaneous resolution. So this is a important graph. As you can see, TSH, represented by the yellow line, is high, especially in the first few days of life. In fact, we have the TSH surge, and it is associated with a non-shivering thermogenesis of the brown adipose tissue. T4 and T3 level progressively increases until it reaches a stable value. Therefore, any suppressed TSH paired with abnormal T4 and or T3 is diagnostic of neonatal thyrotoxicosis or hyperthyroidism. So let's see, for example, this one is an infant born from a mother who is not taking methimazole or PTU. You can see that the patient has neonatal Graves' disease because FT4 is abnormally high paired with a suppressed TSH. And as you can see, TSH at this level should be at least more than 30 or 40. So it's easier to diagnose, unlike in other conditions in adult. So in the next slide, you can see that if the mother is taking anti-thyroid medication or that the neonate is preterm, then there's a possibility that the abnormality will manifest clearly on, let's say, day 5 to day 7. And it is more variable among preterm infants because of the maturity in their hypothalamo-pituitary thyroid axis is not yet established. So these are the clinical manifestations of neonatal Graves' disease. You have IUGR, low birth weight, premature birth, frontal bossing and triangular fasces, microcephaly, irritable newborn, hyperactive newborn, feeding difficulties. In fact, in some series, the neonatal mortality approaches 20%. So cardiovascular exam is very important. It will reveal tachycardia and bounding pulse. Although rarely, they also manifest with cardiomegaly, arrhythmia, and persistent hypertension. So the hyperthyroid stare is common, but not a true Graves' ophthalmopathy. The patient or the neonate has warm, moist skin, and there's diffuse and large goiter, but it's not usually that large that you can miss it if you'll just base your diagnosis on that. Okay, so we want to emphasize that prenatal clinical follow-up and laboratory tests are the best indices for anticipation and evaluation of neonatal Graves' disease. Maternal TRAB is strongly correlated with neonatal Graves' disease. However, as I emphasized, availability and turnaround time are barriers. So if TRAB is unavailable or positive, you should regard the newborn as at risk for developing neonatal Graves' disease. Okay, so just to briefly discuss on how we evaluate neonatal Graves' disease, we want to emphasize the need for evaluation in the 3rd trimester. And if the maternal TRAB is negative, neonatal Graves' disease is unlikely, and only clinical follow-up is recommended. There is no need to absolutely repeat your thyroid function test in the newborn. However, if the prenatal maternal TRAB is positive, especially in the 3rd trimester, of course, we need the age-specific values to interpret it. We should measure the infant TRAB at birth. And if 3 times up more than the upper limit of normal, measure TFT as well, and then correlate clinically. Serial tests at baseline, day 3 to 5, and day 10 to 14 may be warranted if you cannot still commit that the patient has or has no neonatal Graves' disease or thyrotoxicosis. How about for infants that only come to attention after birth? What we do is that infant TRAB is measured, and if positive, TFT is correlated with clinical manifestation, and likewise may be needed to serially test at, of course, baseline, day 3 to 5, and day 10 to 14. So once we measure the infant's thyroid function test, the results may vary into one of these. So it may be diagnostic of neonatal Graves' disease, then we should treat the patient. If it is all normal, you should just follow clinically. The probability that it has developing Graves' disease or neonatal Graves' disease is very, very low. For those with transient hypothyroidism and other borderline results, they also deserve biochemical repeat testing. Okay, so this is another presentation of the same algorithm, but I want to emphasize in here is that once you classify the neonate as low risk, no more biochemical repeat test is needed. And once you classify the neonate as having neonatal Graves' disease, then it's time to treat, even you're still not on day 3, 5, or day 10 or 14. But if you are on the borderline, like you have not yet committed whether the neonate is low risk or high risk, then you need to do serial testing. And an increasing level of your FT4 is indicative of developing neonatal hyperthyroidism. So what do we do? How do we treat? For asymptomatic thyrotoxicosis, we define this as absence of overt clinical manifestations of neonatal Graves' disease, and the FT4 is less than 2 times upper limit of normal. There is no consensus, but some would advocate treating even if it is just 1.2 times upper limit because they're worrying about cognitive impairment, but we'll try to give a few details on that. For symptomatic thyrotoxicosis, of course, treatment is warranted, and the goals of treatment will center on temperature and oxygen management, fluid and calorie intake, and of course, the use of these medications. So we need to follow up the biochemical and clinical parameters as well, and eventually maybe we can stop the antithyroid drug once this condition resolves. Okay, so this table shows you the medications and the dosing. However, the key points that I just want to emphasize here is that methimazole is a drug of choice because of the hepatotoxicity associated with PTU, especially in children. And when you use beta blocker, and the goal is to reduce the heart rate, but sometimes it can also cause hypoglycemia and hypotension. So you need to watch out for those occurrence, especially among preterm neonates. Now they are prone to hypoglycemia. If iodine will be used in the form of Lugol solution or your SSKI, make sure that it will be given 1 hour after giving your methimazole. And then for severe cases, you may opt to give digoxin for heart failure, but make sure to discontinue your beta blocker, and you can also use steroid for severe cases. So there are other abnormalities associated with neonatal Graves' disease, and these are the transient primary hypothyroidism, which I will not discuss in details, but usually the transient primary hypothyroidism is brought about by the antithyroid drug taken by the mother, the thyroid blocking antibody, which is very rare, and some hypothesizes that there is a thyroid disintegration. The follicles are not very responsive with the central axis because of the derangement that was present during development. And the next one is your transient central hypothyroidism. Of course, it's central, so the TSH is either low or normal, unlike in primary that the TSH is high. And the main reason for this is hypothesized to be impairment in your HPT maturation as well. Or they say that the thyroid receptor antibody can traverse the pituitary and block the receptor there. Okay, so I think this will be discussed further by our pediatrician, and the management of hypothyroidism will be comprehensively discussed later, but it is important to remember that repeat testing may reveal resolution of hypothyroidism, it may unmask thyrotoxicosis, or it may show you persistent hypothyroidism. If the individual or the neonate is persistently hypothyroid, then it is time to give levothyroxine until you are absolutely sure that euthyroidism has already taken in place. Okay, so hypothyroidism after 2 weeks invariably needs to be treated. And sometimes it is prudent to continue treatment until 2 years of age before withdrawal of treatment and by increments. So that's the way to remember it. 2 weeks to start and then 2 years to continue. So these are some long-term effects, but as I have mentioned, causality is not established. The evidences are not as robust as in hypothyroidism. In the early 80s, they thought that it is associated with intellectual impairment, but recent studies, bigger studies, would tell you that no, the individuals or the neonates eventually caught up in terms of growth and in terms of intelligence. However, we should also take note that these studies correlate maternal hyperthyroidism regardless of whether the neonates develop Graves' disease or not. So we need stronger studies that will really enroll neonates with Graves' disease. So interestingly, exposure to high level of thyroid hormone during peri and neonatal period gives the child a 1.5 risk of developing attention deficit hyperactivity disorder later in life. And again, this does not denote causality, only association. So this is my last slide. So what are the takeaway points? Early prenatal recognition is important in anticipation and management of neonatal Graves' disease. Clinical follow-up and repeat testing is warranted if the index of suspicion is very high. Short-term effects can be severe and life-threatening, and hence management should be prompt and aggressive. Finally, long-term effects are associated with neonatal hyperthyroidism, but we need further studies for that. Thank you very much and happy weekend.
So thank you, Dr. Mendoza, for that very comprehensive lecture. We will now proceed with the second lecture to be given by Dr. Velasco.
Okay. Hello.
Yes, Doc. You may proceed po.
Okay, I'd like to thank first the Philippine Thyroid Association for inviting the Philippine Society of Newborn Medicine to this celebration of the International Thyroid Awareness Week. Okay, so my topic is actually about congenital hypothyroidism and its effects, short term and long term, and its management. Next slide. Congenital hypothyroidism usually occurs worldwide. 1:2,500 to 1:4,000. In the Philippines, as of December 2017, it was reported by Dr. Abarquez to be 1:2,618. Lately, this 2019, in the Philippine Children's Medical Center, we were able to have 4 hypothyroid babies, newborns, for 2019, and 3 of them had trisomy 21. Now, congenital hypothyroidism refers to the deficiency of the thyroid hormone from birth, and it may be thyroidal, or CHT, or central or pituitary, or CHC. It may be mild subclinical, where the pH value is about 6, between 6 and 20, and we have normal and T4 values. But after the newborn period, the TSH may go down to 4.5 to 10 units. Okay. The moderate to severe, however, has a higher TSH value of more than 10 units per liter. So in this timeline, you can see that there is a surge postnatally of the TSH. This is due to the cool in utero environment. But in the preterm, the surge is attenuated. If the term is about 60 to 80, the preterm is about 30 to 40. After a week, there would be rise now of the T4 and T3. However, at 3 days of life, there would be now metabolic adaptation. And this is the time when best to do the determination of the T4 and TSH. At about 1 week, there would be a fall of the TSH to 10 and a rise of the T3 and T4. And after a month or so, there would be gradual decline of the T4. Next slide. There are 5 types of congenital hypothyroidism. First of all, we have the primary or thyroidal congenital hypothyroidism. An example of this would be thyroid dysgenesis, wherein you may have an aplastic, hypoplastic, or ectopic thyroid gland. And you may also have here maternal medications causing primary thyroidal congenital hypothyroidism. Next slide. The secondary hypothyroidism. Next slide, please. Is heralded by usual T4 that may be low, but the TSH is normal. Okay, so example of which is TRH unresponsiveness and the multiple pituitary deficiencies. Note that the third is peripheral. Next slide, please. And the common example of which is resistance to the thyroid hormone receptor. Next slide. We have the syndromic congenital hypothyroidism. We have the Pendred syndrome with hypothyroidism, deafness, and goiter. And we also have in our country many instances of trisomy 21 associated with congenital hypothyroidism. Next slide. And the fifth is transient congenital hypothyroidism, which is seen mainly in the premature, in those who were given anti-thyroid, whose mothers had been given anti-thyroid drugs, and then also transplacental passage of the maternal TSH receptor blocking antibodies, and congenital hepatic. Next slide. So how do we differentiate permanent versus transient? Of course, permanent means that it is permanent, lasting, with the need for lifelong treatment. We have the primary, secondary, and peripheral. And then transient, you usually have temporary thyroid deficiency, and usually it may only last for about months or years, up to 2 to 3 years. Okay. Let's go to thyroid dysgenesis. This is usually sporadic, but there are some studies that show that it may be genetic on the basis of familial cases, minor morphological abnormalities among first-degree relatives of those with thyroid dysgenesis, and a high incidence of associated extrathyroidal malformations. Let's go to this case number 1. case number 1, wherein the mother during her first trimester was a chain smoker. At 34 weeks, she was hypertensive. So she was advised restricted salt diet. At 37 weeks, she gave birth by C-section to a term-looking healthy infant. The newborn screen was indicative for congenital hypothyroidism. The serum T4 was 15, while the TSH was 25. So what does the infant have? What is the cause? And what should be given? Okay, next slide. So a normal T4 but an increased TSH is implies congenital hypothyroidism. So what may be the cause? You'll be surprised the patient had iodine deficiency, and so what would be given L-thyroxine? Actually, the iodine deficiency may be happening in babies whose mothers were hypertensive with restricted salt intake. And likewise, it may also occur in mothers who had been, in babies who had mothers whose smoking caused the thiocyanate to decrease the iodine in the urine and the breast milk. And adverse effects of this iodine deficiency include increased perinatal mortality, hypothyroidism due to thyroid dysgenesis, and transient hypothyroidism. Okay, and usually these babies are also, if monitored, they may have to be given also L-thyroxine. The secondary or central congenital hypothyroidism is referred to also as hypopituitary, and usually there are also signs of deficiency of the pituitary, hypothalamic, and hypothalamic pituitary portal circulation, resulting to a diminished TSH. So that's why these babies, they may be hypothyroid with low T4, but their TSH is normal. Okay, so it is rarer than the thyroidal type in that it occurs in 1:20,000 to 1:80,000 the general population. Note that these babies usually have signs of deficiencies, like we have seizure, we have hypoglycemia, difficult feeding. Okay, and so we are possibly referring to some hypopituitary deficiency. So usually an MRI is needed to rule out these abnormalities, as well as to guide in genetic testing. Okay, let's go to the next slide, please. We have the third type, peripheral CH, or peripheral congenital hypothyroidism, which usually results from peripheral problems in the thyroid mechanism, metabolism, and transport and action. Okay, next slide. So let's go to the second case scenario. A 40-year-old mother gave birth to a baby who had trisomy 21. Okay. At 2 days of life, the baby was noted to be jaundiced with forsa. The newborn screening was done, but the results are not yet in. He was treated as a case of early onset sepsis. But then after a week of treatment, the patient still was with poor sac and persistent jaundice. So what should be done? Next slide, please. Okay, so trisomy 21 is now associated with hypothyroidism. And at this time, at about 7 days of life, the patient had, aside from the patches of trisomy 21, there was note of large tongue and also low hairline and brittle hair. So serum T4 and TSH were done, which showed low levels of T4 and high level of TSH. So this is actually congenital hypothyroidism. Next slide, please. Next slide. So syndromic congenital hypothyroidism may also be seen, okay, in trisomy 21, wherein there's a defect in the other organs other than the thyroid gland. Okay, next slide. Let's go to the third scenario. The mother with Graves' disease, already mentioned earlier, had maintenance of propylthiouracil. She gave birth to a preterm infant. What should be done? Next slide. Next slide, please. Okay. So, usually babies who are born to mothers who are taking anti-thyroid medicines, usually a cord blood screening for T4TSH may be done. But if not done, usually it may be done after birth. So the baby had a T4 of 6 and a TSH of 21. So this baby warranted treatment with levothyroxine at the dose of 10 milligram per kilo per day. Okay, and then this will be adjusted depending on the result after 2 to 3 weeks and the monitoring thereafter. If the requirement decreases gradually, then the hypothyroidism in this instance is transient. Okay, next slide. By the word transient, CH, it is temporary and it may last for only about months or years. And
Dr. Abdelosa. Okay, so we'll check Dr. Velasco.
Okay,
Yeah, go ahead, Doctora.
trying to check. Okay na? Oo. Okay. Transient CAH is also the one that is commonly seen among our preterms, and the most common among the preterms is the transient hypothyroidism of prematurity. Next slide. Next slide, please. Okay. Hypothyroid baby may not be symptomatic at birth. Usually, 95% have no symptoms. Why? Because the T4 levels are not that low. And there is already a transfer from the mother. Okay? And likewise, there is a conversion of the T4 to T3. So that if there is no locally available T3, there is low serum concentration. Next slide. But next slide. So there are some babies who are frankly hypothyroid when they are born. And usually they have that patches of dull look, puffy face, and thick tongue that is sticking out. Okay. Next slide. So initially also, aside from the fasces, they may have persistent hyperbilirubinemia, edema, then umbilical hernia, and anterior fontanelle that is enlarged. However, later they may have lethargy, poor feeding, macroglossia, constipation, dry and sallow skin, coarse cry, circumoral pallor, and hypothermia with monthly. Next. Next slide. So on PE, you will have usually the presence of decreased muscle tone, very large fontanelles, and then abnormal size of the hands, fingers, arms, and legs. So they have also slow growth, as you see in the graph. Next slide. So for diagnosis, we depend on the maternal history, the physical examination of the baby, the newborn screening, and serum determination of T4 TSH, and also radiological procedures. Okay, next slide. So when is the proper ideal screening time? Actually, it is supposed to be 2 to 4 days. However, in our hospitals, we start at 24 hours. So, short of the screening can be done at 24 hours. Next slide. So in this case, it's 11. Anyway, a baby who has clinical signs of hypothyroidism plus
Dr. Belen.
O, na-disconnect siya, Doc.
Yeah. Okay, we're just waiting for her to reconnect.
If you have any questions or comments, please type them in the comments and Q&A boxes.
So, if we have confirmed hypothyroidism, there's still a need to do other tests to determine the etiology, like a radionuclide uptake and scan, the ultrasonography, then the serum thyroglobulin, and then also urine iodine. However, if, for example, the TSH is not high, okay, but the T4 is low, then this may be central hypothyroidism, but you still need to do tests to rule out any pituitary hypothalamic deficiencies and abnormalities, and also have an ophthalmologic exam to rule out optic nerve hypoplasia. Next slide, please. So a radiologic study with presence of absence of distal, femoral, or proximal tibial epiphysis may of intrauterine thyroid hormone deficiency. Now, there are other findings that may help, like we have poor development or of the osseous
I think Doctora is trying to reconnect now. Okay, Doctora, you can go ahead.
Next slide.
Doktora?
Next slide.
Okay po.
Yes.
Okay po, go ahead.
Next slide, please. Okay, these are the effects of congenital hypothyroidism. In the heart, usually there may be risk of arrhythmia. Adipose tissue, there would be decreased basal metabolic rate with poor feeding. There would be muscle weakness with poor tone. There would be delayed bone age and even short stature. And then in the nervous system, there would be retardation of the physical, mental, and sexual growth of the patient. And then gut, we have persistent jaundice. Then also we have in the lipoprotein, we have heterogeneous profile and also sluggishness. Okay, next slide, please. So in the heart, usually there is an increase in arrhythmia and also effect on the ventricular septal wall. Next slide. Next slide. Adipose tissue as a result of the reduction in the food intake and VMR, as well as weight loss and with problems with next. The delayed bone age may be a result of low resorption, which is studied by Caracas. Okay, so if it is the patient is not treated, then this will lead to short stature. Next slide. Van Steenbergen had studies on the bilirubin, and they found out that these hypothyroid babies had disposition to cholestatic jaundice as a result of a disruption of the bile flow. Okay, next slide. Next slide. Next slide. Okay, the following slides will just show us the long-term effects of hypothyroidism, mental retardation. Okay. And then next slide. Developmental delay. With this developmental delay, there would be associated gait abnormalities, dysarthria, mutism, and autistic behavior. Next slide. How mentioned in this table, the different scores of those with mild, moderate, and severe congenital hypothyroidism with regards to affective behavior, fine motor and gross motor, language, and personal social behavior. Next slide. So there were studies also regarding the sensory neural deafness seen in babies
Doktora?
Na-disconnect siya ulit, Doc.
Yeah. So we'll, I think she's going to reconnect again.
Intermittent yata.
Yeah. We're just waiting for Dr. Velasco to reconnect.
So while waiting, if you have any questions or comments, please just type them in the Q&A and chat boxes.
Ayan. Doktora?
Okay.
Yeah, we can hear you now. Proceed po.
Okay. With regards to sensory neural deafness, maybe due to the study of Chow et al., wherein they noted that out of 27 children, 25% had still abnormal auditory brainstem evoked potentials. Okay, they surmise that the prenatal maternal T4 production does not provide complete protection of the developing central nervous system of the fetus. Okay, next slide. Just mentioned that the hypothyroid status may also cause an atherogenic profile. So with treatment, there would be less of cholesterol, triglyceride, and lipoprotein. So there would be less atherogenic profile with treatment. Next slide. So next slide. It's very important that we emphasize that the timing of screening should be within the first week. We mentioned about 24 hours, although the ideal is 2 to 4 days. And for the preterm, because of the slow rise of the TSH, the testing may be repeated at 4 weeks of life. Those with maternal history of antithyroid intake or a family history of congenital hypothyroidism, determination with the T4 TSH may be done to the cord blood screening. Okay, and then the best combination is actually primary T4 and PSH. Okay, so this is the treatment. As much as possible, if you see a high PSH, even if the T4 is not that high, okay, it's not that low rather, then with symptoms of hypothyroidism, treat with levothyroxine. If the TPO antibody is positive, treat with levothyroxine. And if the TSH is as high, more than 40, then of course treat with levothyroxine. Next slide. So do not delay the treatment. As much as possible, you have to treat the patient even before you have received the official result of your confirmatory test. Okay, next slide. Especially if the patient is symptomatic. Now for secondary CH, this is usually associated with pituitary hypothalamic deficiencies. If you see, next slide please, hypoglycemia, seizure, and other pituitary problems, no, as well as gonadotropin deficiency like micropalus, then perhaps it is best to do an MRI and also treat already your patient even if the TSH is not that high. Okay. Next. But whenever treating central type, you have to rule out the possibility of deficiency of CAH. Okay, so definitely to prevent hypoadrenal crisis, you have to treat with cortisol first before giving levothyroxine. Now for sick babies, the preterm, the extremely preterm, then you have to repeat the test at 1 month of life, and if there is persistence of high TSH, okay, then low T4, then we have to treat. Okay, next slide. This is just to emphasize to you why we have to really
Dr. Velasco. Yeah, Doctora, go ahead.
yeah, next slide, please. So we have to screen early in the first week of life, then as much as possible treat within 2 weeks of life, and then make sure that we give the tablet, there's no suspension, so as much as possible we crush the tablet and have it put in the either milk or water. Okay, and it should not be given with antacid with simeticone. Next slide, please. Should not be given also with iron, calcium, and soy and fiber. And the bioequivalent form should be the one given. Okay? Because those that are unbranded may not be bioequivalent. Next.
Doctora Belen.
Treat every 1 to 2 months in the first 6 months, and then 6 months to 3 years. Repeat the monitoring every 3 to 4 months, and then after 3 years, you have to repeat every 6 to 12 months. Okay, next slide. So it's very important also to assess the permanence of the congenital hypothyroidism. If there is no, or there is an ectopic thyroid gland, this is permanent. If the initial TSH is 50 and there is no increase thereafter, then therapy of at 3 years of age. And the TSH increase is not high after the therapy of, then consider this permanent congenital hypothyroidism. Okay, next. Okay. The prognosis depends on the, of course, the start of initiation of treatment and the compliance with treatment. So if it is started within 2 weeks of life and it is continued thereafter with continuous monitoring, then the prognosis is good. Although at the end of, let's say, 3 years of life, there may still be minimal traces of developmental and mental delay. Okay, next slide. So it's also important to note that the preterms are prone to develop hypothyroidism. And the goal of therapy is it should be within 2 weeks for T4 to normalize and for TSH within 1 month. So as much as possible, early treatment and compliance with treatment. So I mentioned about this effects of congenital hypothyroidism. Okay, next slide. But we should be worried more of the long-term effects like mental retardation or intellectual disability, then developmental delay, and behavioral abnormalities, sensory neural deafness, um, speech delay, or mutism, and atherogenic profile. Okay, so my last slide is you have a fairly early diagnosis is the essence. So we have to diagnose within the week, first week. We have to treat within 2 weeks. Okay. And if left untreated, when the baby may have cerebral palsy, mental retardation, developmental delay, and deafness. Okay. I think that's about all. The next slides will be references. So thank you to newer strategies. The hypothyroid newborn will grow not to be dull and sluggish anymore. Okay, thank you.
Okay, thank you, Dr. Velasco, for that very informative question. So we will now proceed with the open forum. For the first question, what if FT4 and TSH is extracted in a newborn at the 3rd day of life and the results showed elevated results? How can we classify the patient? Or should we repeat the test at 2 weeks old? Or will we treat the patient? So I think so.
It is
Yes.
a dilemma considering that the TSH is positive. The TSH is elevated, but the T4 is also elevated or normal.
Elevated.
Because it is possible that the T4 elevated, then it's better to check and repeat the T4 TSH. Especially with newborn screening, the results may not be in the first week of life unless it is a panic result.
Okay, so for the next question, for Dr. Eric, should we always use free T4 rather than total T4 only?
Yes, free T4 is considered to be more accurate, and especially in conditions wherein binding of the hormones will affect the level. So it's always better to use free T4 level. Well, that's from our standpoint. I don't know if in the Pediatric Society if they still use T4, total T4, or a combination of that. But I think if I will choose one, I will always use free T4. For T3, if needed, I think you can either choose free T3 or total T3. As what was mentioned in the previous lecture, total T3 is less expensive, and number two, the binding percentage bound is not significant as in your T4.
Okay, thank you. For the next question, how about newborns from mothers on anti-thyroid drugs? Do we still follow the cutoff of TSH of more than 40 to start treatment, or is there a different algorithm for it?
Is she referring to newborn in which you're suspecting hyperthyroidism or hypothyroidism?
I think hypo, doc. If the hypo, I think, doc.
For hypothyroidism, we don't just,
yes,
if you already started it, If we already started it and we are monitoring in the next monitor, the TSH is going down, then that's a good sign. But we still do not discontinue treatment.
Okay. For Dr. Mendoza, Doc, how do we follow up the treatment of immune-mediated hyperthyroidism in fetal? Do we use TRAB, or when do we stop treatment?
Okay, so upon diagnosis that the TRAB is elevated, we check for the thyroid function test and correlate clinically. If we think that the patient or the individual is hyperthyroid, then we institute treatment, especially if the FT4 is above 3 times the upper limit of normal. And then we repeat the thyroid function test, not the TRAB anymore, because it is expected that the TRAB will disappear from the fetal circulation because the TRAB is not produced by the neonate. So we just follow up based on the thyroid function test. At first, if it's really severe neonatal hyperthyroidism, we check the TFT twice a week. And then from there, we can do less frequent monitoring, like once a week, and then do it every 2 weeks until the goal is met, which is down titration of your anti-thyroid medication, and eventually we are expecting resolution of the hyperthyroidism. Because if it does not resolve, some studies will tell us that it resolves usually after 2 to 3 weeks, but there are cases in which it can continue as long as 2 to 3 months. So if it did not resolve, then we should consider other causes of a primary hyperthyroidism, which are rare. As I have mentioned, these are the genetic genetic mutations that causes hyperthyroidism.
Okay, thank you, Dr. Eric. For Dr. Velasco, should we discontinue levothyroxine on the day that the blood will be extracted for FT4 determination, or should there be a time interval in between stopping the drug and taking the blood, extracting the blood?
At the newborn age, if we are monitoring, okay, then we do not stop the levothyroxine. However, at about, let's say, you plan to have the therapy off, let's say at 2 to 3 years of age, you discontinue 4 to 6 weeks, then do the repeat testing.
Okay, thank you. For Dr. Velasco, I know this is not common. This is actually my question. I know it's very rare. Do we often encounter thyroid nodules in newborns? And if ever we encounter them, how do we manage them?
So far, I have no experience with thyroid nodules. You refer?
Okay, thank you. So I guess that ends our open forum. I'd like to thank all the participants for this lecture. We will have the closing remarks from the president of the Philippine Thyroid Association. Thank you, Dr. Velasco and Dr. Mendoza.
Thank you, Doc.
Thank you very much to our two speakers. And we are very happy that we were able to enlighten everyone regarding the issues on the newborn. And I would like to thank all the other organizations who collaborated with the Philippine Thyroid Association, the Philippine Society of Reproductive Medicine, the Philippine Society of Maternal Fetal Medicine, and the Philippine Society of Newborn Medicine for having this joint webinar series during this International Thyroid Awareness Week celebration. We do hope that everyone really appreciated these webinars, and we hope to have more collaborations in the future. Thank you very much.